Dr. Gonzalez talked about a specific issue, for example, the bone marrow transplants on breast cancer patients. I would go one step further and look at the entire body of scientific knowledge in medicine and question whether or not the very basis of that knowledge is off. And what I'm speaking about specifically is what they call the gold standard, which is a double-blind, placebo-controlled trial, which is a large-scale trial on hundreds and sometimes thousands of patients. The very nature of that assumes that everybody's the same, that all breast cancer patients are the same. And everybody gets a protocol, and either that protocol does well or another protocol does better, and it's assumed that since this is the best protocol and you're a breast cancer patient, you fit into this. This really ignores the individual differences between patients. And I know Nick's work with his cancer patients and ours is very, very much individualized. We actually are doing chemo-sensitivity testing, and yes, there's not a lot of data behind that. I'll go into that if you want to. But the chemo-sensitivity testing, which is now actually going to be going, quotes, mainstream. I understand that Memorial and Mass General and Dana-Farber and MD Anderson are going to be working with a test developed by Johnson & Johnson and some Boston researchers on chemo-sensitivity testing. We've been doing this for 5.5 years. We actually take a look at the patient's cancer cells and determine what they respond to. And what we found is that in hundreds and hundreds of breast cancer patients, there are no two patients that are identical. No two patients respond to the identical chemo drugs. No two patients have the identical molecular structure so that the targeted agents work the same. No two patients, let me just give you an example. Avastin, for example, was once approved as a breast cancer drug. And recently it was disapproved as a breast cancer drug. It was never a breast cancer drug. It's actually a targeted agent that targets something called vascular endothelial growth factor, or VEGF. And some breast cancer patients have that, and some breast cancer patients don't. But since all breast cancer patients are tried with it, it's a false study. It means nothing.
How does something like Avastin get known as a breast cancer drug? Because a lot of breast cancer patients start using it?
It's easier for the pharmaceutical companies to continue a type of research, which is research that's always been done. So, there are millions and millions of breast cancer patients in the U.S. So, of course, if Avastin gets approved as a breast cancer drug, it's a huge financial success. It's much more difficult to check every single breast cancer patient. Does this one express VEGF? Does this one not express VEGF? And to actually do a study that has some meaning is much more difficult, much more expensive. So what I wanted to finish by saying is that the very structure of the so-called scientific evidence that we have is faulty, is very faulty. And the type of treatment that we do, for example, one of the types of treatment we do is insulin potentiation therapy. Almost every patient comes into our office and says, well, if this is working so well, why aren't there studies that show IPT, insulin potentiation therapy, works as well as conventional chemotherapy? And the reason is, think about it, who funds all of the research in medicine now? Where's the money coming from? It's the pharmaceutical companies. Can you think of a pharmaceutical company that would be interested in funding a study that shows you only need 10% of its drug? I mean, it's just not going to happen. So, as Dr. Gonzalez said, the very basis of scientific research in the U.S. has to be questioned. So what we call evidence-based medicine is really a catchword for pharmaceutical-based medicine. And yet, on the other side, there's plenty of evidence. Dr. Gonzalez talked about Dr. Beard's work on pancreatic enzymes. There are doctors that are doing very good work, for example, Dr. Agarwal on curcumin in cancer patients. All of these natural spices that have been used for thousands of years have a tremendous amount of data building on them. Are we going to see a large-scale, double-blind, placebo-controlled trial on thousands and thousands of cancer patients with curcumin? Who's going to pay for it? It's not a patentable drug. It's just not going to happen. The whole movement in medicine now is to standards of care and one-size-fits-all and algorithms. You can pretty much substitute a computer for a doctor in that kind of system because everybody's going to be able to get the same treatment. It's just not going to work. People weigh different amounts, their bodies work differently, their livers work differently, they detoxify medications differently. It's just an incredibly complex machine that the human body is, and it's not going to work if you don't individualize the treatment.